My mouse is being a little funny. All right. So we know that aneuploidy is maternal age-related, both in vivo and in vitro. We know that miscarriage rates are higher for in vivo pregnancies with older women, and we know the same is true with in vitro. So we do know that aneuploidy is an egg phenomenon. We also know that mitotic errors lead to mosaicism. So this is just a little illustration. As we have cell division happening, if we are mishandling an embryo somewhere along the way and with maybe perhaps a temperature change, we can induce potentially a mitotic error, which would then be passed on to subsequent generations of cells. And we spoke a lot about this paper, and I think this is an important one to sort of touch base, that we know that euploidy rates in donor egg cycles do significantly differ between fertility centers. And this was an incredibly sobering paper for me, because that's an incredibly broad euploidy range between centers, from 39.5% up to 82.5%. So what's causing these differences in euploidy between clinics? Is it an egg issue? And if it's truly euploidy, which is touching again on what Dave McCullough was saying, then it should be something to do with the egg, more in the range of superovulation, stimulation protocols, recruiting eggs that would not normally be ovulated. You know, we could be having some post-mature eggs. I'm really intrigued by the FSH to HMG ratio. That also impacts progesterone elevation at the end of the cycle, so it might be intriguing to tie all of this together as we go further. Certainly egg and embryo handling, with the spindle being incredibly temperature sensitive, and we know that there can be rapid changes with minor temperature fluctuations and pH changes. Or do we have an artifact of the biopsy itself and the testing? So to delve into that a little bit more, and I think this sort of illustrates what Dave was discussing, that when we have mosaicism, there's a broad spectrum of mosaic embryos that could have any range of diagnosis. So this first embryo, if we pulled all normal cells, the green cells being normal, we would diagnose this particular mosaic embryo as euploid. Conversely, the embryo at the bottom here would be diagnosed aneuploid, but would truly be mosaic. And I think that's what's getting into some of what Dave's trying to discuss, that the results that he's seeing are the results from the biopsy, not necessarily the embryo itself. So, so just a little bit of a graphic representation. So is mosaicism normally occurring, or is it a lab-induced, or is it an artifact with testing? And so I think this starts to go back to Jason Swain's paper, which David introduced as well. There's so much more to culture medium, and in the early days, you know, when you would go to ASRM, everyone would ask, what culture media are you using? What culture media are you using? As if that was the, you know, the special sauce that everything revolved around. And it was all about the culture media, and the media companies were the first ones to be thrown under the bus if somebody's pregnancy rates tanked. So now we know that there's a lot more than just culture media. It's a whole culture system. And within that culture system, we have to consider things like plasticware, the size of the drops that we're culturing in, the number of embryos that we're putting in those drops. Are we doing single embryo culture? What's the relative size of the embryo to the drop? Whether we're doing an oil overlay and how protective that is for preserving pH and preserving temperature as well. Certainly, we know that CO2 impacts the pH, and that's obviously a big one. And finally, the oxygen, and certainly low oxygen. Everybody's pretty comfortable with saying that low oxygen is definitely the way to go. Now, within that culture system, though, that culture system exists. If we sort of shrink that culture system down, well, first of all, actually, before I say that, all of these factors can interact together, not just necessarily independently, but there can be cumulative effects of all of these different items. Now, when we take that culture system lives within a laboratory. So here we have our culture system with all the different factors, and again, by no means comprehensive, because I think it was Rusty Poole came up with over 200 different variables that could go into producing an embryo through in vitro fertilization. So within the laboratory that culture system exists in, that culture system is also subjected to the air quality from that lab, from the various incubators that we could be using, whether they're benchtops or big box, the various equipment, the micromanipulation equipment, the refrigerators, and the benches and the isolettes that we might be using, and of course the embryologists. Now that laboratory, again, can have all of those factors interacting together along with the culture system to produce impacts. Now that laboratory also has external factors coming in, the patient, the stimulation, the retrieval, the gamete quality, how the embryo transfer is performed, and the luteal support. And again, just scratching the surface on the really most obvious ones. So maybe one of the more important questions should be, how do you use your culture media, not what culture media do you use? And I wanted to just mention this quick example because within the Life Global media series alone, there are two different types of media. There's global and global total. And if you want to get the same pH range with global media, you need to use a CO2 of approximately 6.5% to get the same pH around the 7.222, 7.2345 in there. You need to be at 7.5% with global total. So again, how we use those media is really important in that culture system. So Dave already mentioned this great paper, which is a wonderful review. So I'll push on from that. Within this review, Jason Swain mentions the various stresses and susceptibilities that embryos have to stress. And the biggest, all of these various stresses impact the embryo. We know that eggs are incredibly susceptible. The one caveat that I would say, and I think this reinforces nicely from Dave's, is that we also know historically that 2PNs were actually quite stable. So 2PNs were the stage that we would freeze at the, when we were slow freezing. They survived very well. So they were relatively stable as opposed to the early cleavage stages where they're a little more susceptible. We've got more cells that can impact. And those cells we saw when we slow froze, if we slow froze an 8-cell embryo, frequently we would have 1 or 2 cells not survive. So mosaicism by biopsy embryologist varies a lot. So when we start to tease out some of those different factors, one of the challenges that we had, if we wanted to look at the laser situation, how do you design a controlled laser experiment with material that's highly variable from a limited number of embryos for research? And what we did in our group was we looked at some human embryonic stem cells, and we targeted those with a laser. We had control cells, cells that we would subject to a normal sort of moderate pulse in our lab use, and then we cranked the laser all the way up to maximum power. And what we found was that there was no change in the euploidy or mosaic rate in the biopsy samples. But I want to caution, because I don't think that means that you should go out and just gregariously go crazy with your laser use. Because when we were hitting those cells, we were definitely destroying them. The cells literally would go brown and atretic looking with the maximum pulse hits. So what you're doing to the remainder of the embryo, needs to be thought of. But the important thing was, from the biopsy perspective, the laser use was not inducing artifactual changes. And Frank Barnes has done some of the same work, and he didn't find anything when they were targeting with the laser on their actually embryo material. So the question is when to biopsy and when to cryo. Do you wait for the embryo to prove itself? Do you wait for more cellularity? Do you consider the cryodynamics of an early versus an expanded or a hatched blastocyst? Certainly the fluid content is a consideration if you're freezing a fully expanded hatched blastocyst. Maybe not so much if you're collapsing those blastocysts before you freeze them, before you bit them. And certainly you're balancing handling concerns if you're dealing with a completely hatched blastocyst. I just wanted to mention quickly, particularly in the COVID days, that micromanipulation setups, I'm still amazed that there's still a fair amount of mouth pipetting going on in the world when I go out to different labs. And I really think there's not a lot of need to mouth pipette anymore. We've got some great various tools, and I think it's worth, I just put that plug in there. There's a lot of variability in the size of the biopsy pipettes that different labs are using. A lot of labs are still using 30 to 40 micron biopsy pipettes that were really designed for blastomere biopsy. And depending on the technique that you're using, that might or might not suit you well. In our hands, a smaller biopsy pipette in the 20 to 25 micron range facilitates easier trophectoderm biopsy. So one of the things we wanted to mention as well was that laser settings are important, and there's different kinds of lasers, fixed and static, all the various brands of lasers, and that it's important to target appropriately. And there's a lot of variability between labs with the laser pulse. So this is just a summary of what you might want to see in a lab. You would want to see this dish. Hopefully most people are familiar with what that dish would be sitting there. It's basically just a Petri dish with some dry erase marker on it. And when you hit with the laser on that dry erase marker, you can see the increasing pulses from 1 to 2 to 3 to 4 to 5, all the way up to 10 millisecond pulses. If you go down to this one, and I've certainly been to labs where the laser is just not functioning properly. And if your laser is functioning like this one, obviously there's an issue because you're not targeting properly. Hopefully your laser is going to line up so that you're appropriately hitting your target. If it doesn't, then you need to get into your settings and explore around a little bit. So I thought we'd have a quick look at some, I'm seeing a different screen than you, oh, there it is. Okay, it was a little slow kicking over to the Trophectoderm. So this is a typical Trophectoderm biopsy pull and cut. So again, just pulling and stretching, typical standard biopsy that most people would do. The reason we like those smaller biopsy pipettes is because it plugs the hole a little bit better and the biopsy doesn't shoot up the pipette. This particular biopsy is just a different way of looking at it. These embryos obviously have been hatched ahead of time. These ones were hatched on day 2. What we did with this particular embryo was sort of turned it on its side to do the biopsy from the side, which you'll see. And it's still the same pull and stretch and cut with laser to pop that biopsy. But rather than pulling straight out, it gave us a little better purchase on the embryo to be away from the inner cell mass. So Trophectoderm biopsy protocols we know can affect clinical outcomes, and this is a paper that came out fairly recently looking at whether you should pre-hatch embryos on day 3 or hatch at the time of biopsy. And this group was getting better results from not pre-hatching and giving the embryos that extra exposure. And the one thing they did do was they removed about 1/4 of the zone in the breech at the time of biopsy. So here's a quick look, and this particular video was shared by Peter Naj. One of the nice things you can see is when he takes the hit here, You can see he's getting a nice clean cut on the zona, so his laser's nicely focused. It's going to pop in, grab some cells for the biopsy. And so that one was done without any pre-hatch. It was just collapsed and then breached at the time. So it was pre-collapsed, but not pre-breached. All right. So what do we know about different biopsy techniques? In this particular study, they looked at the pulling and pulling technique versus flicking. And this is just a small study from MSERM last year, showing that the pulling and flicking methods did not differ in terms of rates of chromosome abnormalities. So I wanted to have a quick look at the flick technique. So the pressure is released on the blastocyst to allow grabbing a hold of the cells. And aspirating some of the cells. Lining up on the holding pipette. And I know there were a few people in the audience doing this technique. It looks incredibly traumatic and scary, but it does seem to be very effectual in the right hands. Okay, quick video now on what we would do at Yale for loading buffer into the PCR tube. We like to drag it up the tube just a little bit if possible. It allows a little better visualization. We don't want it too far up the tube because obviously the cell needs to be in the bottom of the tube. And then to look at biopsy washing, what we found is there's sort of what the testing companies recommend, which is passing the biopsies through drop after drop after drop, and then there's the reality of what actually happens in all the various labs. So one lab I was in actually spotted down 14 different 8 microliter drops to rinse through. So this was for one biopsy, second biopsy, third biopsy. So 3 biopsies were washed through the same dish with a couple of like drops to rinse your pipette. That particular dish, by the time it was spotted out and those 3 biopsies were rinsed through, was out for over 10 minutes. And you can imagine the osmolarity of those drops that are relatively small is probably evaporating. So again, a lot of variability between labs. This is my true confessions. This is how we do biopsy washing at Yale. We don't pass through all those different drops. We use a much larger drop, 50 to 100 microliters. And we'll pull the biopsy. This is just cleaning up the drop a little bit. But you'll see, this is Jonathan actually, going in. Jonathan's going to pick up the biopsy and do some pipetting up and down to rinse it from the top of the drop to the bottom of the drop. So it gets a fairly thorough rinse, but it's not rinsed from drop to drop, where you're a little more likely to lose the biopsy because the biopsy is so small going from drop to drop. Okay, this is a visualization of the biopsy loading into the tube. So what you'll see is the pipette coming in here. And it'll come back on the screen just a little bit better. But if you watch closely on the tip, you'll see the biopsy exit the pipette right there. So we like to visualize that as we're loading the cells. It just gives us the confidence to actually see the biopsy going into the tube. And I know there are labs that don't do that. They just shoot the biopsy in there and don't visualize it, but we like to see it. So here's a paper from Foreman et al. Looking at fertilization method with IVF versus ICSI. I wanted to mention this quickly just because it's becoming a lot more popular, a lot more acceptable, certainly in the US, to be using IVF for PGTA. So this is reassuring that the findings on this paper are that IVF and ICSI, NGS, PGTA had similar rates of euploidy and aneuploidy. and no result embryos. So chance that they might have a slightly higher rate of mosaicism, but we'll have to get some more data on that. So in summary, I think it's a good opportunity for us to reflect on whether we're causing harm with PGT. And maybe perhaps PGT is our opportunity for introspection to be better clinicians and embryologists. Maybe it's actually showing us where we're making our mistakes in the lab. And so I'm really excited about Dave McCullough's data as we start to ferret out a little bit more what we're doing as embryologists and where we can be better. So I think we're really opening a window for insight into our culture systems, which I think is just going to benefit us. So I would hate to see us not continue to pursue PGT. So I also think that it's important for us all to remember, even though we're embryologists, to not lose sight of all of the patients that are having miscarriage, the miscarriage rates. For those older patients that are not doing testing, the time lost for a miscarriage is considerable, and there's a considerable emotional burden. So I think we need to continue to move forward with this technology, and the technology is rapidly changing, so it's exciting